Hello, everyone. My name is Hayden Latham. I am a third-year resident at the Medical University of South Carolina. My primary research mentor is Dr. Gwyneth Lazenby. I'm going to talk today about the impact of integrase strand transfer inhibitor use during pregnancy on viral suppression at delivery, as well as infant outcomes based on our data from a statewide cohort. Integrase strand transfer inhibitors, also known as INSTIs, are a class of antiretroviral therapy, or ART, for the treatment of HIV. NCs have only been approved since 2007, but have quickly become a favored agent as their use results in more rapid reduction in HIV RNA viral load, as well as a higher barrier to development of drug resistance. Raltegravir was the first agent approved, but many new NCs, including elvitegravir, dolutegravir, and bictegravir, are now available, and importantly come as single tablet regimens. Raltegravir has been recommended as a preferred agent during pregnancy since 2015, but acceptance of other NCs has been slower in coming. While some smaller studies have demonstrated successful virologic suppression with the use of NCs containing regimens in pregnancy, other studies have questioned the safety of these drugs. For example, one study of dolutegravir showed an increased risk of neural tube defects. While subsequent studies have since called these risks into question, data surrounding use of other NCs in pregnancies has been limited. The purpose of this study was to obtain a large statewide database of pregnant women with HIV infection in order to achieve an adequate sample size to evaluate the effectiveness of NC regimens in suppression of viral load. Our secondary aim was to determine potential adverse pregnancy outcomes, such as preterm birth, small for gestational age, fetal loss, and perinatal HIV infection related to NC use in pregnancy. We sought to establish this by conducting a retrospective cohort study using data collected from the South Carolina Department of Health and Environmental Control Enhanced HIV/AIDS Reporting Surveillance System. We included pregnant women with HIV-1 infection who delivered between the years 2008 and 2019. We excluded those women who had no recorded viral load or ART regimen. We then compared groups using Wilcoxian ranked sums test and chi-square analysis. Using this database, we were able to identify a total of 591 pregnant women with HIV for a total of 832 pregnancies and thus HIV-exposed infants. Unfortunately, 517 of these pregnancies had no ART recorded, leaving us with a population of 315 pregnancies. Of those, 159 were maintained on INSTI-containing regimens, with 156 that did not include INSTIs. We subsequently further broke each category down into non-INSTIs but protease inhibitor containing, as well as non-INSTI and non-PI, and then each individual INSTI drug. Here is a look at our primary findings comparing INSTI-containing versus non-INSTI-containing regimens, broken down by viral load suppression at delivery. Viral load was divided into three clinical categories of less than 40, or undetectable, 41 to 999, or still under the threshold to proceed with vaginal delivery, and greater than 1,000, or requiring C-section after treatment intrapartum. As you can see, there is no statistical difference between viral load suppression at delivery. In regards to adverse pregnancy outcomes, INSTI-containing versus non-INSTI-containing regimens were similarly not statistically significant across examined variables, including gestational age at delivery, rate of preterm delivery, birth weight, classification of small for gestational age, or child testing HIV positive. We then explore comparisons of viral load suppression across different ART classes, as well as amongst specific INSTI drugs. As you can see, there was no significant difference in viral load suppression across INSTI drugs. Interestingly, viral load suppression was inferior with protease inhibitor containing regimens, with the rate of cesarean delivery statistically higher at 56% in the PI containing group compared to 40% and 30% in the INSTI and non-INSTI non-PI groups.